Good evening, everyone. Hi, I'm Rachel from StuffThatWorks, and I'm very excited to be here today with Dr. Noga Minsky. Dr. Minsky received her medical training at Cornell University, NYU, and Tel Aviv University. She specializes in endocrinology and diabetes and served as the medical director of the Diabetes Alliance and the telediabetes lead at Mount Sinai Hospital. Today, she's an endocrinologist at Sheba Hospital in Israel, which is ranked one of the top 10 hospitals by Newsweek magazine. And there, she provides clinical care, leads original research, and telemedicine initiatives. The purpose of our session today is to offer reliable answers about diabetes, specifically in the context of the COVID outbreak. There's still so much confusion and uncertainty about this virus. And while everyone across the world is concerned about COVID, for those of us with chronic conditions, the questions are particularly pressing. Today, Dr. Minsky is going to start off by sharing some background and facts about diabetes, both type 1 and type 2, and then she's going to answer some questions that our community members have asked over the past week. Finally, we're going to open it up to you, those of you listening at home. So if you come up with questions as you're listening, please feel free to type them in the chat, and we're going to make sure to get to as many of them as we possibly can. Dr. Minsky, thank you so much.
Thank you, Rachel. It's a pleasure. So we'll get started. The topic of my talk today is diabetes and related conditions in the era of COVID-19. So we will discuss today diabetes and COVID-19, as well as risk factors related to diabetes as they pertain to COVID-19. Lastly, we'll discuss how to stay healthy given the existence of these chronic conditions. We will not discuss the transmission of COVID-19, drugs targeting COVID-19, or vaccines to prevent infection. We won't discuss the pandemic forecast. These topics were actually touched upon by Professor Eyal Leshem in a previous session, recorded and available on the Facebook page for StuffThatWorks. Please have a look below. So a little bit of background. We have here a graph showing the situation of COVID cases in the world. So while the disease was first detected in China in December, by March 11th already, the World Health Organization declared it a pandemic and a global emergency. We have the most cases worldwide in the United States, and followed by India, Brazil, and then Russia. There are 28 million cases worldwide. So these are some numbers that were originally presented by Professor Leshem a couple of months ago. These are the statistics coming out of Wuhan, China, when the disease was first detected. So it appears that the outcomes of COVID-19 infections, at the time it was thought that 80% of cases are mild or where patients have no symptoms or symptoms such as cough, sore throat, shortness of breath, new loss of taste or smell, muscle pain, nausea, vomiting or diarrhea. 15% had severe disease needing hospitalization and oxygen, 5% critical requiring intubation, and 2% loss of life. However, fortunately, the true risk for severe disease and for death appears to be much lower when we look at studies where they tested entire populations for exposure. So in these studies, we've actually seen in some populations as many as 50 or 80% can actually be asymptomatic. So the true loss of life may be around 0.4%. So that's a little bit more optimistic. So let's move on to diabetes, okay? So in the USA, they conducted a study over 88 hospitals, more than 1,000 patients, and they looked at hospital records from March to April. Among 570 patients who died with COVID-19, the mortality rate was 15% in hospitalized patients with diabetes versus 6% without diabetes. So we're looking at a much higher mortality rate. In England, we can actually they can do wonderful, very cohesive investigations of the whole population because of the National Health Service. So here in the study, they looked at all hospitalized patients between March and May. And they looked at the risk of diabetes that it poses for in-hospital death due to diabetes. They actually detected about 24,000 in-hospital deaths and they looked at the odds that diabetes poses for death, and they adjusted this odds calculation for demographic variables as well as circulatory disease and heart failure. And for type 2 diabetes, this adjusted odds was nearly twofold, and for type 1 diabetes, the adjusted odds was nearly threefold. So another study from England, where they could again look at the entire population, they looked at the weekly death rates between the first week of 2020 up to week 19 of 2020 in patients and people with diabetes. And they compared the death rate in 2020 to the previous 3 years. So we can see here that in fact the death rate is higher in 2020 related to COVID and also not related to COVID. And in fact, over this entire period, the excess death was 50 to 60% higher. Furthermore, in this study, they also demonstrated that patients who had poor diabetes control, as measured or assessed by hemoglobin A1C levels, had higher mortality. And that was true for people with both types of diabetes. So an A1C, A1C is, hemoglobin A1C is a measure of how much blood is attached to glucose, and it gives you an average of estimated glucose level for the past 3 months. So A1C of 10% or 86 millimoles per mole versus good diabetes control, which is an A1C of 6.5 to 7% or 48 to 53 millimoles per mole. So a kind of a high A1C compared to a target A1C. For most people with diabetes, the target is less than 7. This high A1C raises the risk 2.2-fold for type 1 diabetics and 1.6-fold for people with type 2 diabetes. With type 2 diabetes, the higher risk even began with a lower A1C of 7.6, and it rose with increasing levels. This was a similar trend with type 1 diabetes. So high glucose levels actually impair our immune system. So our defenses are down when our sugars are up. There were other risk factors for severe disease and mortality in this study: male sex, older age, kidney disease, stroke, heart failure, and lastly, and importantly, obesity. So obesity is obviously associated with type 2 diabetes. It's also an important independent risk factor for severe disease. So let's have a look at how we assess healthy body weight. So we use this measure of body mass index, or BMI, which is the weight in kilograms divided by height in meters squared. So a normal weight is a BMI of 18.5 to 24.9. Overweight is 25 to 29.9. Obesity is a BMI of 30 and above. And we see here there are different classes of obesity severity. So we know from a study from Italy of 482 patients in Bologna, that even mild obesity, so a BMI of 30 to 34.9 compared to the non-obese population, really increases risk of severe disease and also death. So the death rate is 1.7-fold. The need for ICU admission is nearly 5-fold. Another study looking at 7,000 patients from the Kaiser Permanente's health network in California also showed that obesity increases the risk for mortality. And here, higher BMI of 40, there was a 2.7-fold increased risk of death, and this risk just kept on rising with higher BMIs. So it's important to also mention that there are other risk factors related to diabetes that increase the risk for disease. So the first three on this slide are actually independent risk factors. So chronic kidney disease, heart failure, coronary or ischemic heart disease are all independent risk factors that increase the risk of severe disease and mortality. Hypertension is a question mark at this point. We're not sure if it's an independent risk factor as of yet. So maybe all of these risks look very dramatic to you, the risk associated with obesity, the risk associated with diabetes, but they're really all dwarfed by the risk associated with advanced age. So using a healthy, a comparison group, young adults, okay, we see that there's a 4-fold higher risk of death for people with COVID who are in their 30s, 10-fold higher for people in their 40s, 30-fold higher for people in their 50s, and we're talking about multiples of hundreds when we get to older ages. So just to mention that older age is of course associated with more chronic diseases, and this risk is, or these odds for severe disease are attenuated by when we control for comorbidities or other illnesses. And lastly, recently it was demonstrated that actually frailty is a larger risk factor, or better at predicting the outcome from a COVID infection than both age or chronic diseases. So it's important to try to age healthy with less chronic disease, or have those chronic diseases in check, and also and stay strong and not frail. So let's talk about how to stay healthy. So the 3 W's to reduce the risk of COVID-19. So we want to wear a mask, wash your hands, and watch your distance, so 6 feet or 2 meters. So general tips for staying healthy: perform home-based exercise when it's not possible to do so in a gym, for example, so calisthenics, aerobics, treadmill, etc. Maintain a healthy diet with at least 5 servings of vegetables and fruit. With fruit, you do want to watch your sugars, maybe limit yourself to 2 fruits. Drink at least 8 cups of sugar-free, caffeine-free liquids. With diabetes, you want to monitor your blood glucose levels regularly and adjust your medication doses accordingly to keep your sugar levels in check. Do store some extra medications and supplies if possible. Regarding medications, do not stop ACE inhibitors or angiotensin receptor blockers. The generic drug names for these end in pril or sartan. These are drugs used for high blood pressure commonly, or to protect the kidney, or in patients with heart disease. So initially it was thought that theoretically these drugs may be harmful because they affect the receptors in cells that allow COVID into cells. But actually clinical studies do not show that taking these drugs has any negative effect. Maybe there's a positive effect. The jury is out. But it's important to take these drugs to keep the circulatory system healthy. Generally continue prescribed medication, but hold SGLT2 inhibitors if you have type 2 diabetes when you're sick. So SGLT2 inhibitors lower blood glucose. The brand names for these in the States are Farxiga, Jardiance, Invokana, Steglatro, and the generic name for these ends with gliflozin. So if you have a fever, nausea, diarrhea, vomiting, do not take these drugs during that time because it can promote diabetic ketoacidosis, which we'll talk about, or DKA in a little bit. So with type 1 diabetes, you do want to continue your long-acting insulin even if you're not eating. If you have sugar over 300 milligram per deciliter or 16 millimoles per liter, check your ketones. So ketones are these breakdown products, or these acids that are formed when the body breaks down fat for fuel. And these ketones, when they rise, it can alter the blood chemistry, and that can cause coma and even death. So it's important when levels are elevated in the blood or in the urine to give rapid-acting insulin corrections, and also to drink a lot of water. And if the levels are very high in the blood or in the urine, or there's vomiting or trouble thinking clearly, then you really have to seek urgent medical attention. Statins are lipid-lowering drugs, which are also heart protective. They're recommended for most people with type 2 diabetes. In fact, anyone over 40 to prevent heart disease. People with diabetes have a 2 to 4-fold risk of dying from cardiovascular disease compared to the general population. For type 1 diabetes, when there are other risk factors for heart disease, it also is recommended to take a statin. And statins have anti-inflammatory effects on the immune system. And in studies in patients with diabetes and without, statins have been associated with a lower mortality risk. A little bit about our communities and stuff that works. So we have a very large type 2 diabetes community. We have less in our type 1 community, which is it's a less common disease. We can see that our type 2 community is a little bit older, which is generally true for the disease. We have more female participants in general in our community. And we have a lot of users from English-speaking countries. The United Kingdom, United States, Canada, and Australia are leading here. And we also are analyzing and seeing what people are reporting. So we see that people have reported that after they take their medications, hemoglobin A1C levels, we have a nice spread here. So some take-home messages. So modifiable risk factors, okay, for severe COVID disease: diabetes and glucose levels, obesity, high blood pressure, and cardiovascular disease. So there are things we can do to stay healthy, keep these diseases in check, use prevention, try to lose weight and control these diseases, generally practice social distancing, receive medical care through telemedicine when possible to keep these diseases in check. Continue your medication. Generally, just hold those SGLT2 inhibitors when you're sick, please. Eat a nutritious diet and hydrate and exercise. So in the long term, COVID-19 will go away, but you can start positive changes in your health for the long term now. A few resources I pulled up for you from the United States, England, and Canada for more information. And we'll move on to questions. I'll be happy to answer your questions. I just ask that we stick to, I can answer questions about general medical advice, but not specific medical advice. I'm not an infectious disease specialist, so let's try to stick to things related to endocrinology or diabetes and obesity. Thank you very much.
Thank you so much, Dr. Minsky. That was really interesting, and I know I learned a lot too, both about diabetes on the whole and also about our specific communities here at Stuff That Works. We have a few questions that were gathered over the week and sent in advance, so I'll start with those. And then, of course, anyone out there who's listening, if you'd like to send in your questions, we'll get to as many as we can. Do you recommend taking supplements? I've heard something about the Indian herb called gurmar, that it can reduce blood sugar. Is it dangerous for people with diabetes?
So thank you for that question. So certainly a lot of us are spending less time in the sun these days, and so we need the sun to make vitamin D. So if you're not spending a good amount of time in the sun, then certainly supplement on vitamin D. That's important, especially for bone health. We don't have very good evidence that vitamin D or healthy, good vitamin D levels prevent disease. It's really just an association with health, as far as we know. Many people do take all sorts of supplements, vitamin C, D, zinc, green tea, echinacea, to try to boost their immune system. But research hasn't actually shown that can prevent getting sick. And there are other unproven treatments like colloidal silver. Oleander plant colloidal silver may even be harmful. And as far as gurmar, that's a Hindi term for this plant, Gymnema sylvestre. So it's used in Ayurvedic medicine, actually, for both obesity and diabetes. Mm-hmm. And so there are some studies, or very, very small studies, showing that it does help with diabetes. And according to the European Food Safety Agency, there is a safe dose of 400 to 800 milligrams of this extract. But we don't really have very big studies showing its efficacy or its safety, so I can't really recommend it. And we don't know about its effect on COVID per se.
Okay, thank you. And something that we actually got this question from a few different people. It seems like there's always different recommendations about diet. Eat this, don't eat this. And sometimes they're conflicting. Like one person says one thing, another person says another thing. What diet would you suggest? And maybe, I don't know if there's a difference between type 1 and type 2.
Okay, good question. So generally it's recommended just to eat a healthy diet, okay, for the immune system, for general health, and to promote heart health, because we do know that with diabetes, the number one cause of death is actually cardiovascular disease. And that risk is really increased. So we want patients to consume, or people to consume their carbohydrates from whole foods, so whole grains, fruits, vegetables. If milk should be low fat, proteins should be lean, meat or fish or legumes. Minimize red meat or processed meat. And as far as fats, fat quality is more important than fat quantity, okay? So we used to talk about saturated fat, now we're talking more about the trans fats being unhealthy. So trans fats are these partially hydrogenated oils. That's how you can recognize them on food labels. And it kind of makes the fat more solid at room temperature. And so you can find them a lot on margarine or shortening or baked goods. So watch out for those. Try to stick to your healthier oils, olive oil, canola oil, a lot of fiber. For most people, about 28 grams of fiber. Reduce sodium, should be not more than a teaspoon all day. Wow. Avoid sugars, obviously, and sweetened beverages. And drink a lot of water, as we discussed. So that's as far as general recommendations. As far as type 1 diabetes, what we really have to focus on is controlling the carbohydrates, because carbohydrates are turned into sugar in the blood, and then we give patients insulin, which is the hormone that helps glucose to go into the cells. So there needs to be a matchup between the glucose and the carbohydrate. So we really have to measure the carbohydrates similarly to how we measure insulin these days. Although that may be changing with newer technologies in the way of artificial pancreases, so the way these new kind of integrated continuous glucose meters and pumps are coming out. So really a lot of exciting things coming our way.
But those are sort of an automated way to match the carbohydrate intake with the insulin to sort of care for those sugars.
Right.
Cool, thank you. This question is about chronic pain, and I know so many of the communities on StuffThatWorks, there's people who are coping with chronic pain. If someone has chronic pain and it's not properly treated, does this affect their glucose levels?
Yeah, so pain is really common in people with diabetes, unfortunately. So back pain especially, and also neuropathic pain. So that's pain due to damage to small blood vessels, and in turn that leads to damage in small nerves. So that's commonly or very often in the feet and the hands. So with back pain, it's more to stay fit, do exercise, physical therapy, lose weight. Okay, with neuropathic pain, it's important to also look for the underlying cause. It's not always the diabetes. Sometimes it's low vitamin B12 levels, which can happen commonly in patients taking metformin or glucophage. Yep. Also, it can happen, or also in type 1 diabetes, where vitamin B12 deficiency can be autoimmune. And also in the elderly, vitamin B12 deficiency. But actually getting back to your question about pain, yes, absolutely, pain makes it much harder to control diabetes.
On a physiological level,
Right. Stress, even emotional pain will do that. So it's important to control pain for quality of life, but also for diabetes control. So just maybe I will, because getting back to supplements for a minute, not everyone's aware as far as pain. So, sorry, I didn't mention actually diabetes control. Proper diabetes control, of course, is important for helping neuropathic pain, besides looking at B12 levels, etc. And lastly, there are some over-the-counter therapies that may help as well. So capsaicin is this extract of chili peppers, which you can rub on the hands and feet that hurt, and it can ameliorate pain for a few hours. There's also an antioxidant, which is very helpful. It's alpha-lipoic acid. So there are actually pretty good studies supporting the use of these agents.
You can get those over the counter. Great, thank you. Someone wrote in, they said, I'm a pump user and I'm having trouble managing my hyperglycemia. What suggestions do you have?
Okay, so as far as managing hyperglycemia, it's really important to have ongoing good care, I have to say. I think that there is maybe a dearth internationally of doctors who really are using pumps day in, day out, and are very experienced in using them. A lot of doctors and family doctors certainly know how to manage type 2 diabetes, but for type 1 diabetes, you really need that experience. So if someone's having a hard time with their pump, certainly they should see a doctor, an endocrinologist who's specialized in that. And if there isn't one in the area, try to see one with telemedicine. But you have to get someone who really can match your basal needs and also your boluses or insulin with food or insulin with corrections.
And just to help make sure that the pump is working right and the balance is correct.
Right. I think someone might have asked something about early morning glucose rises as well. I think I saw that also. Mm-hmm. So with early morning rises, there's something called the dawn phenomenon. So that's a rise in glucose levels that often starts around 2 or 3 a.m.
Okay.
And that's because of early changes in hormone levels at night. Actually, growth hormone in the very early part of the night will cause that. And so we often will increase the basal rate. Basal rate is how much insulin patients are getting.
Through the pump.
Through the pump,
okay.
Exactly. So we'll increase that rate according to needs throughout that early part of the.
So you'll be, even while you're sleeping, you'll be getting the.
Right. That's a wonderful thing that you can do with insulin pumps as opposed to just one long-acting injection.
Great.
It gives a lot of flexibility.
And I imagine the technology about that's just advancing all the time.
It's a very exciting place to be right now. Mm-hmm.
Cool. How does living with other chronic illnesses, I know, again, we have on Stuff That Works platform, we have many people who are dealing with many different chronic conditions. If you're living with other chronic conditions, particularly autoimmune diseases, how does that affect glucose control and management?
Yeah, that's an important question because other autoimmune diseases are really common in people with type 1 diabetes. They certainly seem to have a predisposition for autoimmune disease where the body's antibodies or immune system is actually fighting the body's sees it as an infection, right? So almost up to 30% of patients with type 1 diabetes have thyroid disease where they may have low or high levels. So it's important to monitor those, especially high levels of thyroid hormone can cause rises in glucose levels. Celiac disease affects up to 9% of patients with type 1 diabetes, and eating gluten for these people can actually cause low blood glucose. It worsens bone health, and also a gluten-free diet can be problematic because it can increase weight and also cause glucose level rises if they're eating starches that have a high glycemic index. There's also adrenal insufficiency where the body isn't making enough glucocorticoids, which are hormones we really need to survive. It's fortunately not so common, but when it does happen, people will have fatigue, weakness, and actually they'll have even worse low blood glucose levels. And another thing to remember, there are really a wide variety of autoimmune diseases that can be associated with type 1 diabetes, and sometimes people require steroids or glucocorticoids to dampen down the immune system. Unfortunately, those can really raise blood glucose levels. So when patients take steroids, they really need to be in good touch with their doctor, their diabetes
It sounds like that's a situation where you really want to be monitoring. And is that something that can happen like today and over telemedicine to do that kind of monitoring?
Absolutely, and it's so important. Steroids can also cause DKA, diabetic ketoacidosis. So with telemonitoring, if people are uploading their devices to the cloud securely, then we can see what their glucose levels are and make recommendations.
Great. Someone with type 2 diabetes, they said, what are the optimal times to check glucose levels if I have type 2 diabetes?
Great question. So actually, I think that we have to just remember that sometimes it might not be necessary to really check blood glucose levels, just to keep things light. If people are well controlled just on their diet or or on drugs that don't cause low blood glucose levels, such as metformin or glucophage, we don't have to really obsess with the blood glucose levels. We can check A1C, maybe check it from time to time, see that there isn't some sort of a rise. Checking glucose levels after meals generally can help give us information about what foods we can or can't eat, how foods are affecting our glucose levels. And so after meals, about 2 hours after meals is when we see that peak of glucose rise. And so there we're looking for a rise of no more than 180 in most patients, okay? Now for patients on insulin, we really want to check that, or long-acting insulin, that morning fasting glucose, because that's the most likely time for people to experience a low blood sugar, or less than 70. And then if people are also taking short-acting insulin before meals, then we do want to also check their insulin levels after meals to see how they're responding to that. And also before meals, ideally, to also know when to correct. And that's when people are checking that many times a day or injecting insulin 4 times a day, it really does help to have that continuous glucose, blood glucose meter.
Is that something you find if someone was newly diagnosed with type 2? Maybe the checking would need to be more often, and then once they've sort of gotten into a rhythm and know how to manage it, it can be more infrequently?
Absolutely, that's often the scenario, although we really do stress that if you're on insulin, you have to check your blood glucose, because there can be surprises. Sometimes people aren't aware of their low blood glucose. That's a hypoglycemia, an awareness we call that, and that's very dangerous because the levels can go so low that it can cause a seizure or fainting without realizing. But if someone has just slowly kind of drifted from pre-diabetes to diabetes, and it's really very well controlled with diet, then it's not necessary there's a burden to checking blood glucose levels a lot.
Right.
So we have to use clinical judgment. So really consult with your doctor regarding that question.
Thank you, sure. There's this article, I actually saw this as well, and someone mentioned this. There was an article that went a little bit viral on the web, and it was talking about that actually having COVID could potentially trigger diabetes in people who didn't have it. Mm-hmm. Can you speak to that?
Yeah, that's a surprising finding that's actually been reported several times. And we know that kind of a new high blood glucose level in people without pre-existing diabetes, it's actually a risk factor for mortality. So it's unclear, the chicken or the egg, what's causing what, but there is evidence that there are these receptors, these ACE2 receptors on the insulin secreting cells in the pancreas. They're called beta cells. So these cells can actually be infected by virus, and the virus can actually destroy these cells, it seems. And so that was done in some lab studies, and there was this article published about a 19-year-old who had this diabetic ketoacidosis, so this presentation of very severe diabetes where they had ketones, and he wasn't making insulin, and it wasn't the typical type 1 diabetes where you have antibodies. It really seemed to be destruction of the pancreas. It's a case report, and there are cases. Really, to answer the question, we need to look in the long term and see if people who have been affected by COVID-19 or been infected actually are more have a higher incidence of diabetes than patients who have not over a certain time period. That's the way we'll really be able to answer that question.
I remember when I spoke a few months back to Dr. Lesham, the answer to so many of the questions were, we don't know yet. We don't know yet. And it sounds like there's could it be 10 years down the line that people who previously had COVID are more likely to get diabetes? And it sounds like that's something that it's just too soon to tell.
Absolutely.
Okay. How much exercise? No. I skipped a question. I've heard that both diabetes and COVID can both cause inflammation in the body. Is this what makes COVID more dangerous for diabetics? And is there anything I can do to reduce my inflammation?
Right. So basically, you can get with COVID. There's this hyper response of the immune system. Okay, hyper-inflammatory response, and it seems to be that really is what is triggering severe lung disease. And actually, there's also lots of patients can also get heart inflammation. Okay, so it's true. There is this issue in both obesity and diabetes. there can be high levels of inflammation. Okay, so to reduce inflammation in general, first of all, weight loss, so that's prevention, and then kind of weaker data, more theoretical data, are that having more of a kind of Mediterranean type diet with less processed foods may have anti-inflammatory effects, or more whole foods as well, not as evidence-based. So those are the key, there are just some studies. It's not well established as far as medications for diabetes, what may reduce risk, but there's some speculation. Does metformin or glucophage reduce risk? Do GLP-1 agonists such as Trulicity or Victoza or Ozempic, do those reduce risk? The jury's out. We will see.
Okay. It's another one of those we need some time.
Sorry, the statin. The statins do
Yes.
reduce inflammation, of course. We did discuss that, and most people with type 2 diabetes, of course, should be on them, and with type 1 diabetes, with risk factors for heart disease, absolutely.
Would you say if someone's diabetes, you talked about this a little bit earlier, but if someone's diabetes is well under control, right, then that's also going to be sort of preventative for them?
Absolutely.
Okay, great. You mentioned foods, and I see someone had a question. They said, I eat a plant-based diet only. What are the 5 best foods for diabetes type 2? Top 5.
Oh boy. Can I call on a nutritionist? I mean, the thing is, I think it's hard to answer that question because we really do want to stress a varied diet. So that's very important. It's hard to really reduce things to that level. But legumes are a great source of protein with a plant-based diet. You want to make sure you get enough protein. So tofu, legumes are great. As far as cruciferous vegetables are very nutritious.
So it's like broccoli, cauliflower,
absolutely,
spinach. Okay.
Absolutely. I mean, there is this, in some places, I know in the developing world, they try to kind of guide people in a very basic way, because sometimes people have a lower health literacy in some regions. So they stress kind of eating different colors, so you get different, you're actually getting different nutrients with different colors of food. Mm-hmm. So get your greens, get your reds, okay?
Okay, so colorful plates. This is similar to how much exercise and what types of exercise would you recommend? And can it make a difference in the likelihood that I'll get the virus?
Okay, so we actually don't have very good evidence for that, unfortunately, regarding exercise really reducing the risk. So that study hasn't been done. It's kind of impossible to do, but we do know that exercise is associated with better health overall, a better immune system. And in general, it's recommended, at least in the United States, for example, to get 130 or 300 minutes of exercise, moderate exercise weekly, or 70.
I was worried you were going to say a day. I was like, that's a lot, 2 hours a day.
Or 75, or 75 minutes of more vigorous exercise. So that's aerobic exercise, and then add to that some strengthening exercise. Okay. So anaerobic exercise twice a week.
Weightlifting and
exactly,
calisthenics.
or Pilates.
Okay. We have a Pilates place right now.
Oh, that's good.
Next question is there data about gestational diabetes in COVID-19? Are gestational diabetic women at a higher risk? That's a great question.
Yeah, it is a good question. I remember initially the report said, no, diabetes is not a risk. Pregnancy is not a risk. And then and later studies show perhaps it is a risk. It's not very well established if pregnancy in itself is a risk factor. Diabetes, we know generally, is a risk factor. There isn't enough evidence right now about gestational diabetes per se, but again, just keep those levels under control. The good thing about gestational diabetes, people with pregnancy tend to have lower glucose levels, so what's considered diabetes in pregnancy they're actually pretty low blood glucose levels.
Okay, thanks. Some protocols for COVID-19 include low-dose steroids. Would you recommend the administration of steroids in patients with diabetes? Yes, I knew that was going to come up. So, I do want to say I've had patients before who told me they have refused steroids because they just had such bad experiences with them.
in terms of raising the glucose level. So so as far as low dose steroids or getting dexamethasone in the hospital, this is going to be in a hospitalized setting. So definitely if you're hospitalized for COVID, and someone recommends dexamethasone or some sort of steroid, I recommend trusting your doctor to both treat you for the COVID-19, but also to treat any high blood glucose levels that may occur as a result. So
so follow the doctor's orders, and steroids, don't try it at home, but definitely with the doctor's supervision in the hospital. Okay. Is there a link between, this is a non-COVID question, just strictly diabetes, is there a link between type 2 diabetes and chronic fatigue syndrome?
Okay.
That you're aware of?
Yeah, so actually I'm not aware of that. I can look that up. I mean, it's obviously uncontrolled diabetes is associated with fatigue, but that's an interesting question.
It's actually something that we can come back from if we look at our platform, and we can look at some of the people, the community of chronic fatigue or ME and the type 2 diabetes community, and I'm happy to post some data later about that connection. So we'll post that in the feed to whoever asked that question. It's a great question.
Absolutely.
Paula asked, how do I lose weight while being diabetic?
Okay, good. So let's see. So first of all, lifestyle, so the exercise now and diet, but there are also medications for diabetes these days which can actually really, really promote weight loss. So a note about exercise. So the amounts of exercise that I was recommending previously, the 150 minutes a week of moderate exercise, something like that, that's more for weight maintenance. But for weight loss, you really need to do an hour a day of moderate exercise, or a little bit less of more vigorous exercise for weight loss. As far as diet, definitely be in touch with a dietitian to reduce your caloric intake. No fad diets or drastic diets where you're really reducing your calories without supervision or support from a nutritionist. We have to be careful. And as far as the medications, so we have an oldie but a goodie, which is metformin or glucophage, which promotes a little bit of weight loss in the order of 2 to 3 kilograms. We have the SGLT2 inhibitors, which I mentioned previously, which you can't take when you're sick, but in general, they are good medications. So those drugs also are associated with a similar weight loss, maybe a little bit more than metformin or glucophage. With that drug, you're losing some sugars in your urine. Okay, so that's how it lowers the blood glucose levels. But you also lose calories that way. Okay? And then lastly, you have the GLP-1 agonists. Okay, so that's
a drug type.
That's a drug family. Sorry. So those drugs basically mimic a hormone, or they're analogs of hormones that we make in our guts, which are incretin hormones. So those hormones, besides stimulating secretion of insulin by the pancreas to lower sugar levels, they also work on the hypothalamus, our appetite center, and reduce appetite pretty drastically.
Oh, wow.
So we can see very, very dramatic weight loss with some of those agents.
Okay, great. Thank you. First of all, I want to say thank you so much. If people have more questions out there, you can definitely send them in afterwards, and if we're able to answer them, we certainly will. I really want to thank you, Dr. Minsky, for joining us today. It was a pleasure personally, but more importantly for everyone out there in the communities to have this information and to have you as a resource. StuffThatWorks helps patients figure out which treatments work best using crowdsourcing. If you have a chronic condition, join your community on StuffThatWorks.health. The more contributors, the smarter and more personalized the insights become. I also invite you to check out our podcast. It's called The Patient Is In, and it features stories showcasing what's possible when people are empowered to advocate for their own health or the health of their loved ones. It's available wherever you get podcasts. Thank you everyone for tuning in, and thank you again, Dr. Minsky.
Thank you. Thank you, everyone.